So we're talking about connected devices today, keeping the doctor away. And we've got, each of you will do a quick little introduction, but I'll just read off the list. We have Jonathan Palley from Spire, co-founder and CFO, Lauren Cheung for the Stanford Center for Digital Health. We have Ben Jacobs from Whistle. We have Casper to Clercq from Norwest. He's a general partner focusing on health technology. And Mark Zdeblick from Proteus, putting little chips in pills. I guess let's start from this side. Casper, do you want to give us a little, talk about what you do for a few minutes?
Sure. So Casper to Clercq, I'm at Norwest. We've been in business for about 50 years. I won't go on at length with an ad, but investing really in digital health for the last 5 years. I came out of a background of really working intensively with hospitals and physicians with implantable devices and drugs and drug delivery. And so a lot of my opinions are formed by that. And I won't spend a lot of time sort of talking about philosophy here, but a couple of thoughts. Having spent time on the consumer medical device, consumer device side, so we invested in Basis and Misfit, both of which were sold, one to Intel, one to Fossil, really had that experience of friction versus feedback or something of value for a consumer. And I think that's one of the parts that's missing in healthcare, where we assume a patient will do the right thing for no reason, because there's nothing in it for them except their health, and somehow that seems to be somebody else's problem. So that's one big theme. I think the other theme that I would love to talk a little bit about in the course of the discussion is, are we talking about health and wellness, or are we talking about disease? Because they tend to be very different things and mean different things to different people. So that's briefly it. We're a team of 6 people at Norwest. We're managing about $1 billion, and I think we have about 12 portfolio companies, all in this digital health ecosystem, from consumer all the way to analytics for hospitals and payers.
Great. No worries. Ben Jacobs, co-founder and CEO at Whistle. I would echo a lot of the points Casper already made, so it'll be a good, lively conversation. I know it's the end of the day, so I'm going to wake you guys up. How many of you have a dog or cat? See, I'm going to the side. You didn't think I was going to ask that? There you go. I'm the one who's going to talk a little bit about veterinary care today. So Whistle is a company that makes devices and software in the pet space, aimed at both pets and veterinarians. Our devices can track your dog's location, so if they were to run away, but also can track their activity and other health metrics, including medication compliance. I'm very curious to hear what Mark can offer into our space as well, because that's a huge issue for your dog or cat who can't speak for themselves and they're double medicated or under-medicated by an owner. Talk more about this, but I'm inspired a lot by what Casper said. Actually, one of our board members was the CEO at Basis, Jeff, and now still a general manager at Intel. So I completely agree with the tension around what is a consumer wellness device versus what is a medical device. And that also applies in our field, where there's only 2 or 3% penetration for insurance. So there are significant financial implications. Obviously, there's a lot of complexities in the payer system. In human healthcare and pet healthcare, it's often a very emotional decision of, do I do this treatment or do I put my dog down? And our goal is to hopefully bring you into the vet earlier, and once you get there, have some more information to help inform that decision.
Cool. My name is Jonathan. Built a company called Spire, still building a company called Spire. We built this little device here, this little tiny stone. It's obviously a wearable device solving problems in the mental health and wellness space. So this little guy tracks respiratory patterns, breathing. Ends up your breathing is very closely tied to your mind. When you're tense, you breathe differently. When you're calm, you breathe differently. When you're focused, very focused, you breathe differently. And so our product is able to solve problems among stress, among productivity, and other areas here. So excited to talk about that. We're doing a lot of stuff quite different than what people think about when they think wearable trackers. Our product is much more around real-time feedback, letting you know that you're becoming stressed before you might realize that, and giving you something to do, right? And so, very interested, echoing what these guys said, also talking about how we can change experiences and change perceptions of what these kind of products can do.
Well, remind me to ask you about using that thing for asthma. But first, I guess I'll introduce myself. So I'm a co-founder and chief technical officer of Proteus Digital Health, and we have innovated digital medicine. So we put, as he mentioned, a silicon chip inside of the tablets that are medicines, and we have a wearable device that also detects when you've eaten that medicine. It also measures your heart rate, your angle of repose, other biologics such as temperature. From that, we measure how much sleep you get and how much activity you get, and close the loop, essentially, on medication. So for schizophrenics, for example, if they take their medicines, they can get regular sleep, and we know that they're getting enough sleep. We give them enough medicine so that they get that sleep, but not so much that they get fat. So you can titrate the medicines to therapeutic outcome, as opposed to simply giving them how much they get based on how many kilograms they weigh. And our company was founded on a broad theory, which was to add electronics to existing therapies to make them more efficient. And that's still a valid thesis, I think, not just for our company, but for a lot of the people here. Existing therapies, electronics, make them more efficient.
Great, and I'm Lauren Cheung. Sorry about that. I am the director of Stanford's new Center for Digital Health, as well as a physician. So clinically, I am an internist by training. I do a little bit of primary care, a little bit of hospice medicine, as well as a little bit of non-trauma emergency medicine care. But the majority of my time is actually spent on the design and implementation of clinical products into the health system. So we're really interested in how to leverage digital technologies to improve the health care that we provide for our patients. And that's either from research, from actual practice, clinical practice. So we designed and implemented recently a new virtual primary care clinic, which has been kind of our biggest jump into telemedicine.
Thanks, guys. Is this thing? Okay. Thanks so much. Lauren, I wanted to ask you the first question to get this started, because the title, I think, says it all. Are these devices today keeping the doctor away? And you're a doctor. Are any devices today actually keeping the doctor away?
So it's an interesting topic, and one that has been widely discussed recently. I will say, so our virtual primary care clinic, what it is a primary care clinic that offers patients the ability to do all of their care online. So through email, phone, and video visits, with really coming in person only when they feel they really need to, or when the physician says, I think it's time to come in because I need to examine your belly. Now, as part of that clinic, we do offer virtual wellness coaching, but also connected devices. So patients have the option to send us their data from Withings devices, from HealthKit, from Fitbit. And I will tell you that when I prescribe it, I get almost no uptake. So if I ask my patients to track their blood pressure, I get very little buy-in. Now, if my wellness coach tells their patient, and the wellness coaches have a closer relationship to the patient than I do. They see them on a more regular basis. If they ask them to track their steps, the patient more readily does it. So I think it's an interesting thing, because I think that engagement with connected devices is really not where we need it to be to see any meaningful uptake and really difference in outcomes that we want to see. But I think we have to rethink the model of care, and that goes to workflow for physicians as well as patients, to figure out how do we integrate that data into our system in meaningful ways. I just came back from the American Heart Association conference a few weeks ago, and there was actually this study that came out called the Beat Heart Failure Study. Really, really interesting, because it was a study of about 1,400 patients using remote monitoring tools to prevent readmission in patients who'd been hospitalized for decompensated CHF. They saw pretty much no difference in 180-day mortality, 180-day readmission, 30-day readmission. And so it really begged that question of, is this really going to make a difference? And is it just that we're designing the flows poorly, and so that's not really what's working? Or is it just that people don't want to do this?
What do you guys think? I mean, so the data doesn't really show that there's any difference being made now. So should we be optimistic about this, or should we think, why are we doing this? Why are we up here?
Well, actually, I think a lot of it depends on what data and the quality and the value of the data you're talking about. So if it's a heart failure patient who has just been admitted, just being released to the to the real world, and the number one reason for them to get readmitted is failure to take their medicines, not failure to walk 10 feet or failure to take steps. And I think the other more fundamental thing is that taking your medicine is a reminder that you've got something that could kill you. You've got some kind of disease that's causing you to go to the doctor, and people want to forget that. That's why pacemakers are so great. You get a pacemaker, you forget about it, it just does its job. You can forget the fact that you've got a disease state that gives you a pacemaker. And so the promise of digital therapy is, in the long run, is to get people away from thinking about, I'm sick, I'm sick, I'm sick. And you have an app that, say, for example, I'm taking this pill because now this app is allowing me to donate a medicine to someone in Africa every time I take my pill. So you're playing kind of or if it was me, I'd be detecting my medicines by holding on to my cell phone, and if I took my medicine yesterday, it'd be playing me highlights of the English Premier League, Liverpool games. And so now I'm taking my pill so I can see Liverpool, unfortunately, lose 2-0 to Newcastle. But that's what I would be doing. I'd be changing the storyline. And so it's what you do with the data that's important. And simply giving people data. You took 12 steps yesterday. You took 20 today. So what? So it's the quality, the value of the data, and what do you do with it that's in count. And you have to think about your changing behavior. You're not simply, measuring something with a yardstick every day and giving them a number every day.
I would add to that, and I would add. Oh, there we go. It's just totally different volumes. I breathing sensors, so I can protect my voice just fine. I would add to that and what you're saying and say it's really about closing the loop and creating value for the user immediately. Unfortunately, we have very short attention spans, right? And so I'm not going to do something unless it makes my day better today, right? I mean, we don't have problems with people taking aspirin. When you take it, you have a very short feedback loop in terms of it impacts how you feel, right? And I can say with Spire, because we obviously look at this kind of data very closely, when someone puts on Spire and it's providing notifications that makes their day better, they continue to use our product indefinitely, right? When they put it on and after a couple of days they haven't gotten enough real-time feedback and we can see enough change in their behavior within a couple of days, it's much harder to keep someone engaged, right? And so it really comes down to solving someone's problem and closing that loop very, very quickly that I think determines a lot of it. Whether that's in a very serious clinical condition like heart failure, right? Some of the more consumer stuff we do around productivity, or some of the users we have who have panic attacks, right? And we'll see that they're still having panic attacks over a period of time. But it's all about that closing the loop.
You remind me of something. I hadn't thought of this before, which is if you're measuring in something that a nurse is not going to measure in a hospital, the patient probably says, "So what?" But we've had patients in NHS in England who have used our technology, and we ask them if they'll do a video or something, and we just ask them the question, what do you think? And the answer is that come back is often, I feel like I've got a nurse taking care of me while I'm at home. And that's a really important point, because now you're taking the comfort and the care and the level of attention that you're getting in a hospital, but now you're getting it in the comfort of your home. And so what you're providing is that level of attention at home. And so if what the data you're asking the patient to get at home is not the kind of information that a nurse would gather in the hospital, they might say, why do you think it's important?
And I will say, but I will say that, to Mark's point earlier, what's interesting about his product and some of the other products out there, for instance, you mentioned pacemakers, is that it's about taking, when we think about connected devices, most of the devices out on the market right now require some sort of behavior change from the patient. So they have to strap on something every single day, they have to report readings, they have to do something different. And I don't know how sustainable that is. And that includes even taking your watch and plugging in every third day when it runs out of battery. So we really have to think about what we're designing and what we're creating and whether or not people are going to want to stick with it when it comes to their behaviors. And if they don't see the value right away, they're not going to. And so it is really about creating value in a way that's easy for both patients and providers to really understand that value and really doesn't change their workflow.
A lot of this has to do with the sensors that we have, right? And Jonathan, I mean, I think it's sort of interesting what you're doing with Spire. You have this, I haven't, seen any other sensors that are quite this, I mean, it's interesting, respiration. And it reminds me, actually, Casper, you have experience in the pharmaceutical industry where you're just looking for drugs that will help people, and it's almost like sometimes these things are discovered by accident. And Jonathan, I'm wondering sort of, did you come across this sensor and then try to find an application for it? Or is it more this you were seeking out something?
No, we started with the problem. And so we started with, we knew that this respiratory signal was a very interesting signal, we felt, for a few different reasons. One was its connection to kind of emotional state, right? The second reason we thought it was very interesting was because of the fact that it's one of the few biosignals that we do subconsciously most of the day, but you can actually control, right? So going back to, going back to closing the loop, right? That we could tell someone, you can tell someone about how they're feeling because of their breathing, but then you can take a deep breath. You can change that signal to actually influence how you feel. And so again, we thought closing that loop was very, very important. And then the third reason, more broadly, something you mentioned, is we felt respiration impacts a wide range of medical conditions, right? From what we're doing around productivity and stress to panic attacks and anxiety to asthma and COPD. I actually invented this sensor while living in Beijing, and if you've read the news, the problems that are there. And I actually originally became one of the reasons we became interested in this was knowing, I mean, literally sitting there with some friends being like, we're living here and we're actually killing ourselves. The tragedy of the pollution crisis that exists there, and because our risk of getting a chronic pulmonary disorder later on in life was increasing dramatically. And so we felt if we could take this super interesting signal that no one had been able to capture before and put it into a form factor that had a low enough friction, right? So that the state of the art before Spire in respiration sensing was either a mask, spirometer, right, or a chest strap around your chest, which is just not kind of painful. So we thought, well, we could figure out a technology to capture the signal in an interesting enough way, or accurate enough way that was then low enough friction that there was a lot of different medical or wellness applications that we could solve it. And that's how we got into it. And we spent tons of iterations to figure out the sensor. Yeah.
It's interesting how it's this, you referred to it back in the room as an off-label. The asthma aspect of this is off-label, which is sort of like a drug term. And then I thought, Casper worked in this industry, and I thought I'd ask you, are you out there as an investor looking for like the new sensors that could possibly be like the next drug? And could you talk about that a little? Here, I'll hand you my mic.
Sure. So it's interesting, right? We have looked very carefully. One of the reasons we invested in Basis was that they were the first one to do continuous heart rate monitoring. The hope was actually similar to what we were talking about here with respect to stress, that you can actually look at heart rate variability. When you do the experiment, though, it turns out that heart rate variability is around 60% correlated with stress. And then it's like there's work stress, or there's good stress, there's bad stress, there's anxiety versus horror. So it's incredibly complicated. And the hope was that we could actually have a stress map. There is a device, I think, that costs a lot more, but it's fairly predictive. You drive to work and it goes from green to red, and then you go home, it goes back from red to green. So not particularly useful. So what we ended up investing is a company called Clercq. The logic behind that was that Clercq, so lots of people with diabetes, lots of them do glucose testing anyway, finger sticks. Yes, maybe someday Google will have a Google Glass, we'll all put contacts in our eyes and do glucose sensing. I'm kind of skeptical about the whole idea. But in the meantime, do a finger stick. People are doing that anyway. Why not send that finger stick glucose value up to the cloud? I know exactly when you're testing. I know when you're not testing, which probably gives me a sense of some behavior. I know when you're high, I know when you're low, and I can actually intervene and give you some useful advice about what's going wrong. And I make the analogy of if we wanted to get in shape and run a marathon, for argument's sake, and you said, I'm going to hire a coach, and the coach sits down with you for 15 minutes, I think is what a GP usually does, 15 minutes, and says, okay, 26 miles in 6 months, we're going to do 3 miles next week, and then we're going to do 5, and then we're going to do, I want you to run along on the weekends. Here's your 5 sheets of paper with the training schedule. Here's a log. Come back in 6 months when you're finished with the run. How can we possibly expect a good result out of that? And that's what we're currently doing with diabetes. I think it's absolutely absurd. The problem is it's incredibly hard to change the way healthcare is paid for. Who cares? We're getting there with respect to capitation to some extent. But when we go back to the theme here of, does it keep the doctor away? I think there's a great book by Clayton Christensen. We've all heard of The Disruption. But physicians, I think, are, with all due respect, really good diagnosticians. I think there are a lot more people that are less expensive that potentially have as much, if not equal, empathy with respect to coaching. And so there's a lot of talk about population health these days. The next question is, once you've identified the high flyers or the expensive people, what do you do? And I think the solution actually is to have connected devices with relatively inexpensive coaches who are under the supervision of a physician. Because Laura's not going to have time to, look at your Fitbit data. She doesn't care, doesn't want to look at it. But if a coach were to call her and say, you know what, maybe once every several months, so-and-so is fallen off the wagon, you probably should bring him in for an appointment because I think they're not exercising anymore. Maybe they're depressed, or I expect their cholesterol's gone up. So that's that's the way I'm starting to think about it. There are other sensors. I think Spire is interesting. We've looked at inhalation sensors. They're not very accurate, looking at exhaled nitrous oxide. There aren't a whole lot of, we have to do commodity sensors, which are mostly off of cars and phones. So I think we've got just about everything on the phone that Apple can think of. But I'll stop there. How about pets?
Yeah. Well, no, just to build on what you were saying about wellness coaches, I think we're seeing the same trends in the pet industry, and I'd be curious, I'm sure Lauren has the statistic, I don't know it, for human healthcare. In pet healthcare, the average pet owner goes in every 18 months, and the vet will tell you should come in twice a year, right? So we're 3x off in terms of how often your pet is seeing the veterinarian, and obviously, again, the pet can't speak for themselves. But to Casper's point, a lot of the industry is moving more towards, well, we're not going to fix that problem with vets. There's a ton of supply and demand challenges and infrastructure challenges and payment challenges. Let's solve it with wellness care and an intermediary layer of coaches that might not even be physically present, but are digitally present for you, to provide insights, to Mark's point, on top of data. So if there are devices, not just data for data's sake, but there's a coach that's informed about your specific dog and their specific needs to help with that. Do you know that stat offhand? I guess an average GP visit would be the equivalent of how often to go to the doctor?
So I will say at Stanford and most of our primary care clinics, I think the average visits per year is 2 per year for a patient in a panel. But that's spanning every type of patient from super healthy to very chronically ill. But I think it's a really good point. I don't think, when I think about this topic in terms of connected devices, are we keeping the doctor away? I wouldn't say that we're necessarily keeping the doctor away is such a broad term, but I would say that it's about keeping you healthy without having you have to come into the doctor all the time. And that is exactly, it's using a care team. We're doing it in our clinic where we have wellness coaches who are different than the traditional health coach, because ours are actually certified trainers, also nutritionists. And so they're a very different profile. And their ability to get our patients to do something different based on this data is really great. And then the thing is that at the end of it, they always loop us in. So I think when we look at connected devices and keeping the doctor away, it's not about keeping the doctor away. It's about keeping the doctor informed about what's going on so they can intervene at the right time. So they can intervene when it looks like something bad may be happening or something bad is about to happen. And then filling in that gap between that and the patient using devices as well as other providers, whether they be wellness coaches, nurses, social workers, and I think that's, for me, what I see this becoming.
I'd like to go back a little bit to what Casper was saying, and it reminds me that when there's a problem that's a medical problem, that the American response to it is add labor. And we spend $2.8 trillion on healthcare in this country. Of that, $2 trillion is labor. And we only have 300 million people. If we were to use this model for the entire world of, 6, 7, 8 billion people, it's the entire world's GDP just for healthcare, which isn't scalable. Now, Silicon Valley is a little bit better than that. We can design not just for the needs in our own backyard, but for what's beyond. And in this country, you can think of it as that healthcare is kind of an employment program that just happens to provide medical services. Now in South Africa, where they've got 7% that are virulent TB and 7% of the population has AIDS, and they have kids born with AIDS that are managing it for the rest of their lives, healthcare there is a crisis management system. It's very, very different. And thinking of things that are scalable, that go beyond just in our backyard, but that can be applicable to address diseases where it really matters, and it's just not a convenience thing, but it's really getting a job done. Well, there's just different ways of looking at, I think, what you do with your time on the earth.
Well, there's a lot of money wasted for sure in healthcare, right? Which means there's a huge opportunity. I mean, how big do you think the industry is, and where's the money going to come from? Is it going to come from insurance companies, from governments, from consumers buying gadgets? Like, what do you think?
I'm just trying to integrate the last comments, but I think it's interesting because we invested in Omada, for example, which is using now a 10, 15-year-old study, the diabetes prevention program, where they found that if you could do a 16-week program at the YMCA and get everybody to show up on Mondays, you get about a 50% reduction in the onset of diabetes, in the following, in 2-3 years later. And they got significant, about 4%, 5% weight loss in that population, a big randomized control study. So Amada said, why don't we do this online? It's like, think about traffic school, right? Who's doing online traffic school as opposed to showing up in class on Saturday? But it was really interesting because I said, guys, you cannot scale. You have to automate this. And the Amada team said, absolutely not. This has to be a personal connection. And when you talk to psychiatrists or social workers, probably one of the most compelling behavior change things is the human intervention. So I think there's going to be a balance. I think it's, if you've got somebody who really has intractable behavior problems, call it drug rehab, I mean, that is I don't think you can bot that, but I do think that if people are a little bit healthier, you can do things with cognitive behavior therapy, you can do things with automated systems that I think will leverage the current healthcare system. So I guess I would look at it, I don't think it's either, I don't think it's either or. I think certainly when we look at dual eligible patients, Medicare and Medicaid, those folks are costing, $3,000 per month, $50,000 a year easily in healthcare expenses. Well, my colleague who used to work at San Francisco General, he said we had a couple high flyers who were $1 million patients. He said it was worth having a nurse follow them, drive them around, give them an Uber, put them in a hotel, keep them out of the ER. So it depends on what aspect we're looking at, and I would say that top 10% is extremely expensive, incredibly hard to change behavior. A lot of those folks are depressed. They're overeating because they're depressed, not because they're for other reasons. But and then going all the way down to a relatively healthy population at Facebook or Apple, they have very different needs. I mean, we're talking about the worried well there.
Ben, do you think people are care more about their pets' health than their own? And what have you learned?
They definitely spend more out of pocket on it. I mean, that's a fact. I mean, it's a really sad fact, but that is a fact. So, I mean, to throw some numbers
what can we learn from that?
I think pet care, child care, elder care, there's a lot of interesting analogs for quantifying something else besides yourself. We talked about, I think Jonathan said really well, I mean, if I don't get feedback on something that's quantified self very quickly, I toss it in the kitchen drawer, and that's a very well-known fact of connected devices, right? I think we see much longer cohort curves and retention, not for any pat on the back of our product, but just because people love their dogs, to your point. And what can we learn from that? I don't know, to treat ourselves like we treat our pets, I guess. Be the person your pet thinks you are, as the phrase says. But I do think what's interesting from a financial perspective, from our industry, there's $20 billion spent on healthcare in the veterinary industry that's out of pocket. And I referenced that when I was doing my introduction, but you feel that pain more emotionally as a pet owner than you do feel if you have insurance at a Google or a Facebook when you have a health problem. And so I think there is actually a more top of mind, both emotional and financial consideration there. I don't claim to have a solution for what that looks like in human healthcare, but we definitely hear that from both owners and vets of how that impacts decision making.
Interesting.
I was just going to say a lot of, I think, our thesis of where we're going with Spire, to the points I were making before, is that this kind of technology, more specifically the data off this and the feedback loops we can create, are not so much about removing the doctor, things like this, and how do you solve the fact that it's such a big labor force, but how do you make that labor force more effective and more efficient? Because I think if you look at other industries outside of healthcare, what has technology done? Well, technology by and large in most industry has not eliminated people. What it's done very effectively is make people make people more efficient, make the best people be able to have a bigger impact. Across, I used to work in like the call center industry, which very, very different industry, but very, very people intensive, right? People are the number one cost by far, right? But technology has had a huge impact in that, right? As you've been able to monitor people, you've been able to determine performance, right? You can dramatically increase it. You're able to do distribute it and have people working from home, taking calls, right? That industry has been quite transformed with technology, and it is in a similar industry in the sense that 95% of your costs are the human labor. So we see the data we're bringing from Spire and our peers in this space ultimately going towards how do you close sleep loops, how do you make that doctor more efficient, not eliminate them.
And I would say that actually, right now, I don't think the public is ready for us to go all digital with healthcare. So part of it is an education piece. So I think, and part of it is a data piece. So we don't have enough data for patients to feel comfortable that they're getting the care they should based on their connected device data. 10, 20 years, could we? Could we envision that, I don't know if any of you watch Big Hero 6, but there's that big kind of marshmallow man coming in and he basically says, how can I help you today? And 20 years from now, that may be the case. We might be able to replace providers, but we need better use of the data to show us exactly what we should be doing, really advanced algorithms to show based on patient symptoms, based on patient vital signs, based on really everything what they should be recommending. And then we need the education piece. We need to show patients based on this data that it's safe to do so. And we need to do it in a way where they don't feel like they're getting pushed under the rug and being told, the doctor's too busy to see you.
Yeah, it's interesting. One of the things it occurs to me is that a lot of the people designing digital health stuff are young, and they're doing, which is why you see a lot of health and wellness apps for young people who don't need medical care. And I think one of the most difficult things to do when you're young is to put your shoes or your mind in the shoes of someone who's old. Now, since I've stopped coaching soccer after doing it for 15 years, and I have a bit of gray hair, as my daughter keeps reminding me, I'm close enough to start empathizing a little bit more with the people who might actually use the technologies I have. And it's a really interesting and important point in that the friction that we've talked about earlier about would a patient use this? Well, if they're facing going back to the hospital because they are really, really sick, it's a little bit easier to take. And also, to some of your points about how it's used and incorporated into a data, we've had patients in NHS, which is not the most user-friendly place in the world to be sick, where they're completely unresponsive to heart failure medicines. Completely, we took a panel of 264 patients who were completely unresponsive to heart failure, to blood pressure medicines. But then they had a patch, and all they knew was that the doctor would eventually see that data. No real-time app at all, just wearing the patch. They knew it was going to work this way. Half of them took their medicines as prescribed, and lo and behold, their pressure was under control. Half of the balance took their medicines, and lo and behold, the pressure didn't change because these blood pressure medicines don't work for everybody. You have to change some of them and titrate them a bit. And then, of course, the remaining fourth, even though they knew that the doctor was going to know whether or not they took the medicines, still didn't take the medicines. Now, that might influence their ranking on the heart transplant score, which is something you don't need friction about. You don't need to have a protocol. One of the most important lists at Stanford Hospital is who's going to get the next heart when it comes in. And wouldn't it be nice to know who's taking their medicines before that heart shows up?
So you talked about age differences between the people inventing these technologies and the people they're meant for, but there's also a socioeconomic difference too, right? And I wonder if we're getting that. I mean, part of this is access to healthy food. I mean, you guys have touched on nutrition a little bit, but are you seeing anything out there that's addressing that, trying to bring healthier habits to people who, maybe it's partly education, but maybe it's also economics.
I was going to say there, so much of this is tied up in behavior. So much of this is tied up. Because the standard metrics for drug companies is that after 6 months, only 60% of the people are taking the drug they should be taking. even in transplant patients, I think there's probably only an 80 to 85% refill rate. You're going to have organ rejection if you don't take your transplant drugs, and people don't take them. I mean, that's not a value judgment. It just is. So just going back to healthy habits, food. I think if you ask people to take photographs of their food, it's going to last a week. I'm very skeptical about whatever MapMyFitness. It's been demonstrated that if you get people to pay attention a little bit to what they're eating, maybe they'll get in the habit of eating more healthily. But to expect people to log stuff over more than several weeks, I think is crazy. The things that I really like, for example, would be Ginger.io. I'm not an investor in this, but Ginger.io, sort of talk to the invasiveness, basically puts an app on your phone, and it's tracking how often you message, when you message, ambient light, when do you go to bed. And so I can sense whether if you're messaging less or suddenly you're manic and messaging in the middle of the night, maybe you need some attention. So it's going to be, in this Facebook culture where we put everything publicly, maybe health data will become like that. The other one I love is there are a couple companies on the sleep side that will put a sensor, you put a sensor on your mattress. I mean, you basically plug it in, forget it. The failure has been, I've got to turn my phone on to say, okay, I'm going to sleep now. That doesn't work. It's really simple. So I think changing behavior, whether it be good food and so forth, there are tons of really interesting, there's a great book called, Hooked. There's a fellow, and there's BJ Fogg who writes about this a lot, but the idea of using gamification and sort of, little dopamine rewards for nudging you towards good behavior, that's one impact. So in order of preference, I would say coaching, number one, is the human touch. Secondly, some kind of rewards, whether it be economic or behavioral economics, then you can do the nudging, little dopamine responses. And those are all the simple metrics like Facebook, that spinning, that scrolling news feed is super addictive to people. So that's how we have to treat healthcare as in a way to do the things that we're bound to do anyway and just make it easier.
Mark, I thought you put a microchip in these pills, and I didn't realize what a problem this was actually until I talked with you guys. People just don't take their medication. Is it actually, so I guess it's cost effective. What does it cost to put a computer in a pill that you're just going to swallow it? And then what happens to it afterwards? Is it just like...
Talk about your disposable computer. Yeah. Well, there's 10,000 of them per 8-inch wafer. And so ultimately the cost is pennies, ultimately, is what it is. And he's right. The number is about 50%, 50-60% on average is adherence. Novartis, their first interest was in transplant medicine. The number is about 85% half a year out. That's all true. But, something I maybe didn't mention is that we do have the ability to give patients electronic nudges, and it works kind of like this. Well, no, it's actually, they get to decide exactly how they get the nudge. So, for example, if they're taking their medicines, you don't give them a nudge, because if you give an email message every day, it doesn't work, right? So, but if they forget to take their medicines, you might give them an email, right? Another, if it's Sovaldi, it's a high-value medicine that's $60,000 per course of treatment, and each pill is worth $1,000. We've actually had the county of San Francisco call us up, and there's 2 patients have gone through the therapy with ours. One of them was schizophrenic, and they don't remember if they're taking the medicines or not. They forget to take their medicine, this $1,000 pill. They'll get a call from a nurse when they've forgotten to take their medicine in real time to then remind them to take their medicine. Now, a normal heart failure patient who's on our CMB panel, well, we're going to do thousands and thousands of patients this way. We have a laddered system. So if you forget to take their medicines, they might get an email. They still forget to take their medicines, their mother gets an email, or their wife gets an email, or their daughter gets an email. And then that person gives them a call. If they still haven't taken their medicines, eventually the nurse calls them. But you try to bring in the family dynamics. One of the most interesting experiences I had early on this innovation process. I went to a TI designers conference in Texas, and I presented just the idea, literally in 60 seconds, to a table full of electrical engineers who had various levels of management, some in marketing, but they're all double E's. And I just said, this is what it does. It's a chip inside of a pill, and you can detect when you take your medicines. And the guy sitting right to my left immediately said, oh, I know exactly what I'd do with that, and described his own brother who is schizophrenic, and the only thing they talk about at the dinner table is, are you taking your medicines? That's all they talk about. And he said, if you can solve that, man, I would pay a fortune for that. And then, literally, I'm not making this up, 2 other people at the same little conference, private conference, said, I have a friend in the exact same situation. And all you gotta tell me is my brother taking the medicine or not? I don't care about anything else. Then I can talk about deniers.
I want to. Do you guys have any questions? Do you want to back there? Can you?
I had a question. Mark alluded to that, but how is the connected devices and health, is that just a developmental issue, or are any of you looking for solving this on a global scale in the emerging economies, where I think it's more critical, healthcare is much more of a critical crisis?
Well, I can say our technology has been used in South Africa. Sarah Brown at UCSD has been leading the TB world, which is all about wirelessly observed therapy, which works 7 days a week, as opposed to directly observed therapy, which is 5 days a week, because that's when county workers work. And she's taken it to Mexico. And so she's actually delivered and used this with patients in Mexico. And she has taken it to South Africa, looking for funding for that program right now. We also have efforts in China that are underway. We almost have approval from the Chinese agency for TB primarily, and we have approvals in Europe, United States, and almost in Japan.
So I have a question for Mark. So would the pill excrete away, or it'll stay inside after the work is done?
It's a very pure grain of sand. It's a 1 millimeter square piece of sand. Silicon is sand. It's just very pure, and it's been stripped of its magnesium. The copper chloride's been reduced to copper, and if the body needs a copper vitamin, it takes it, and if it doesn't, it just gets excreted.
There's like a transmitter, right? So it's got to also.
It literally
connect
is
to-
just a silicon chip. It has magnesium on the backside, and it has copper chloride on the front side. And if you remember your high school redox equations, the magnesium wants to go to Mg3+, and then the copper plus wants to go to copper. And so one side wants to give an electron, and the other side wants to take an electron. It's kind of like a potato battery with 2 different metals that power up and turn on a light bulb. It's just that you're the potato.
And then it's picked up by some kind of.
Yeah, so the
receiver
patch
that
actually has
then
2 electrodes
The
on it.
patch, yeah, okay.
Right, and so the chip modulates the current, and it
that's
just goes
sent
right
into
through the
your
chip.
computer or the doctor's computer or something.
Well, eventually it goes from there, goes to a cell phone, and that goes to the cloud. And then we have a separate display for the doctor. So they have a triage panel of all their patients in the heart failure, and they know which ones are taking their meds, which ones aren't, which ones need a phone call, which ones aren't, that sort of thing.
Over here.
How do you see the intersection between what we eat? How do you see the intersection between what we eat to the extent that could become connected with our health, given that would also get measured? So apart from the physical activities, you ate your veggies and you ate the veggies that had chip inside, so we know you ate the veggies. How do you see all that coming together?
Go for it.
So Casper, you might have seen it with your venture work, but there actually are some smart spoons and smart forks and things like that out there, which will take and also some devices that, some really cool ones that will, if you take a picture or if you stick your fork in it, it'll tell you if there's an allergen on it. So if you are allergic to peanuts, for instance, it'll tell you if you're about to put a peanut in any shape or form in your mouth. There's also some that will count calories for you. So I think that technology will evolve to the point where we're going to have devices that are your simple eating utensils that are telling you what you're putting in your body. And that's not just, the basic of this is a vegetable, but it'll tell you down to the level of this is, how much protein it has, how much carbohydrate it has. I think we're a couple of years off from it truly being well developed, but I have a couple companies I have seen have come to us with that.
How do you guys think, if let's say we do get there, how would that change the way people eat? Would
The commercial that's
would they
coming
still want
to
the chips?
The commercial that's coming to mind right now is that commercial, and I don't remember what it's for, but there's a guy with a helmet on, and he goes to go grab a hot dog, and then in the helmet it yells no, and then he goes and does something else, and he's like gonna drink a soda, and it yells no. I don't think it'll be at that level, but I think it'll help people make better decisions, because I think it's all about a lot of education. And so if you provide them, people in general, with the tools to understand how it connects to their health, then I think that they're going to make better informed decisions. And I think that's what's really important in all of this.
I would add, I think there's interesting structural changes that are happening very slowly, but hopefully faster, to the healthcare ecosystem that will allow us to start aligning financial motives with healthier behaviors, right? So if you look at some of the things that the Affordable Care Act has enabled among primary care physicians, where basically you can say, okay, I'm going to pay this group to manage this population as opposed to each time you see a doctor. Well, now that group is motivated, and there's incentives built into how healthy. I'm simplifying this dramatically, and I'm not an expert on this, but the basic concept is if you start thinking about paying the healthcare system to keep people healthy or to manage a population and hit certain health metrics as opposed to each time they see a doctor or go to a hospital, well, then insurance companies can start thinking about how do you financially motivate people to actually be engaged in healthy behaviors, right? And we're seeing this in like the corporate space as these kind of products that are obviously not dealing with food, but are dealing with stress and productivity and fitness are deployed to corporate spaces that's being tied to financial motivations around your health insurance premiums and things like that. And that leads to very, very effective engagement. I think if you can tie that to food, you also get great outcomes there.
Well, I think we'll end it on a high note because that would be nice if that actually happened. We're out of time, but thank you guys so much. That was really interesting.